Hello, everyone. Welcome. We're just going to give us ourselves a few more minutes as people are just joining in on the webinar. So please relax for just a couple of minutes and we'll get started shortly. Hello again, everyone. It looks like we still have people just coming into the webinar. So we'll give ourselves just one more minute before we get going. Thank you. So hello, everyone. Welcome and thank you very much for joining us today. In this webinar, what we hope to do is clear up some of the confusion around Itsy food texture testing methods and answer some of the questions that have recently been submitted. We've designed this particular session for those who are supporting individuals in a clinical capacity. For those people who are in food service operations, catering, we will be hosting another session next week on November the 17th. So for those who know of someone working in the food services area or catering, please let them know about our session that is going to come up next week and ask them to register for that. This session is being recorded so that it can be made available to all those who are not able to join us today. All participants at this point is in a listen-only mode. If you would like to ask a question, please use the Q&A function on the Zoom control panel bar. Please identify yourself with your first name, where you're from, and our panelists will do their best to answer your questions in the order in which they're submitted. If there are questions that are on similar topics, the panelists may try to answer them together so that we can get to as many questions as possible today. Certificates of attendance will be sent out to all webinar participants who attend this live webinar. And I repeat, certificates of attendance will only be available to those who attend the live webinar today. If you have joined us online, we will have a record of your attendance. For those who may have joined us by phone, please take a moment to email your name to meetings@itsy.org so that we can make sure you receive a copy of the certificate of attendance. The webinar has not been pre-approved for any CEUs or professional development credits. Participants will need to check with their respective professional organizations or accrediting bodies regarding CEUs or professional development credits. We would like to thank all the wonderful sponsors who unconditionally and generously support the work of Itsy and webinars like these. Without their unconditional support, we wouldn't be able to bring you these educational events. So once again, thank you so much to all of our wonderful sponsors for Itsy. I am thrilled to introduce to you our presenters today, Dr. Katrina Steele, Itsy board member and research lead, Dr. Joe Murray, past Itsy board member. Joe is currently leading helping to co-lead the Itsy implementation in the VA. Dr. Luis Riquelme, Itsy board member, and also leading the translations process for Itsy documents and resources. And then I am Peter Lam, Itsy co-chair, happy to be the host of the webinar today. I think let's just get started, shall we? What are we going to cover today? Well, first of all, I think we're just going to help to refresh everyone's memory about Itsy and what is it. And we're approaching that from a clinician's perspective today. And I think Katrina is going to take us through a bit of exploration of predicted versus expected classifications. We will look a bit more in depth into Itsy testing methods and why might the testing results differ from expectations, and wrap up with Itsy labeling, do's and don'ts, products, materials, and we have purposely left a significant amount of time, hopefully, to be able to answer your questions and have some discussions. Before we get started, we just thought we'd take a quick poll of the people who are attending the session today. So Alan, if you don't mind, get you to launch the poll. So with the poll that you see in front of you, if you could just please take a moment and vote. Okay, we'll give it another 30 seconds as more people are placing their votes. For those of us who may have just joined us within the last minute, there is a poll going on right now. As you'll see in the middle of your screen, please take a moment to vote. We're just trying to get a sense of where you're at in terms of Itsy implementation. All right, it looks like maybe we'll stop the poll there. So everyone can see the results that's posted here. We have quite a variation of implementation stages of the people that are attending the webinar today. Thank you very much, Alan. All right, at this point, I'm going to now hand this over to Katrina, please.
Thank you, Peter, and hello, everyone. So I'm going to get started with a general introduction to Itsy and some in-depth exploration of levels 3 and 4 on the framework, and I'll then hand off to Joe to take us further up the food side of the pyramid. And a key difference that we want to emphasize between Itsy and previous approaches today is that Itsy, the Itsy framework is not a system of diets. and as the NDD was, but rather it's a system of labels or terminology that can be used to describe the properties of foods and liquids based on a set of tests. And you can see the sets of tests that are available on the slide. These have been developed intentionally with the goal of being user-friendly so that they can be performed by anyone. And that means you as clinicians, patients themselves or their family members, or people in kitchens, and for that matter, in industry and in research. Next slide, please. And so this means that the Itsy framework is descriptive rather than prescriptive, and you'll hear us saying that over and over again, I hope. It's really become a message that we're trying to emphasize. By this, we mean that Itsy tests can be used to understand the properties of foods and liquids that are available for patients. But a really key point is that the determination of the levels on the framework that are appropriate for any particular patient is something that needs to be based on assessment by a qualified clinician. One of the main consequences of approaching food selection in this way is that we are very hesitant to give examples of foods or liquids that are representative of the different Itsy levels. And this is because we recognize that consistency of a food or a drink can vary across several different conditions, things like ripeness, freshness, temperature, chilling or reheating processes that have been used in preparing or storing that product. And so one of the most frequently asked questions that we get at Itsy is a question about what level a particular food product is. And our response is always, that depends, or that we really recommend that you perform Itsy testing to determine the answer. And just recently, to give you an example, I handled a question where a clinician asked, where does chocolate fall in the framework? And so I answered that it would be impossible for me to answer that question and guess, because the consistency of the chocolate would depend on whether it was milk chocolate or dark chocolate. It would depend on the temperature, on whether the chocolate had previously melted and then hardened again, on whether there were other things in the chocolate like nuts or perhaps a filling that could be runny, and that might turn the bolus into a mixed consistency. Next slide, please. So the primary motivation behind developing the Itsy framework was to improve safety for people with dysphagia. And we believe strongly that confusion when we're referring to the characteristics of foods and liquids represents a safety risk for people with dysphagia. And our goal is to establish clear communication to eliminate that risk. Next slide, please. So what do we mean by the word safety when we're talking about diets for people with swallowing impairment? Here we mean that a person can swallow food and liquid without aspirating material into their airway, that they can achieve good bolus clearance without leaving material behind in the pharynx, and that they can swallow without material blocking their airway and causing a choking emergency. And so those three goals help us to identify the risky characteristics of food and liquid that need to be managed, such as how thin a liquid is, how sticky food might be, and how large the particles of food might be in a bolus. Next slide, please. So safe swallowing, of course, requires reconfiguration of the pharynx so that it stops being a pathway for breathing and becomes a pathway for ingestion. And this requires closing the entrance to the larynx and opening the entrance to the esophagus, as well as a complex series of muscle contractions that move the bolus down through the pharynx. Next slide, please. And in this animation, you can see that the airway is actually open while the bolus is held in the mouth, but closes as the bolus passes on its way to the esophagus. We'll just let that play again. There it's closing. Next slide, please. In people with dysphagia, we are very concerned clinically about penetration aspiration, or the entry of material into the airway. And we recommend thickened liquids because we understand that these liquids move more slowly and that this gives the patient extra time in which to get their airway closed before the bolus reaches the danger zone. And several papers now, including a recent paper from my lab, confirm that the risk of aspiration is significantly reduced with thicker liquids. Next slide, please. So here we have an example of a video fluoroscopy where we see a patient who is unable to achieve functional airway protection, resulting in serious aspiration. There it goes. Next slide, please. So when you as a clinician recommend thickened liquids, we think it's important that you should be clear about how thick you think the material needs to be. And on this slide, you see an illustration of the Itsy flow test, which has been designed to look at how much material is left behind in a standard 10 milliliter slip tip syringe after 10 seconds of flow. And provided that you use the correct syringe for that test, it is valid and highly reliable for determining whether a liquid falls into levels 0, 1, or 2 of the Itsy framework. That's the white, gray, and pink zones on the card. As you can see, however, once we get up to levels 3 and 4, there's a fork on the side of the card and a spoon on the top of the green zone, indicating that additional tests are needed to confirm the consistencies of liquids in that zone. Next slide, please. So the first of these additional tests is the Itsy fork drip test. And this test confirms whether a liquid is behaving more like a level 3 moderately thick liquid or like a level 4 extremely thick liquid. Level 3 liquids will drip through the tines of the fork in dollops or strands, whereas level 4 liquids will mound on top of the fork and won't drip through. So to demonstrate this, we're going to move to a demonstration video that I recorded earlier in the summer. Peter, you can run the video.
So for this first virtual active demonstration, we're going to look at the fork drip test. And we're specifically interested in confirming whether a product is level 3 or level 4, or maybe not behaving as expected. I want to start with a liquid that you might have some assumptions about, which is honey. And I chose this because, of course, we used to call liquids honey thick liquids, and that's a really ambiguous term. And so I have here some commercially available honey, and I've preloaded a syringe so that I can show you how it behaves in the flow test to begin with. So I have a clean syringe here, and I'm going to fill it with 10 milliliters of the honey. So I'm at 10 milliliters on the syringe, and now I'm going to use my watch as a timer and let it drip into the bowl for 10 seconds. 5, 4, 3, 2, 1, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now, you may have noticed that only a couple of drops came out of the syringe. Really, we're still at 9.8 on the syringe. And so this is probably in the moderately thick range, but it really didn't flow. And this honey may have a property called yield stress, where it has some surface tension and doesn't flow very well. So the next question regarding this honey is, how does it flow through the tines of a fork in the Itsy fork drip test? To do the Itsy fork drip test, you need to be able to immerse your fork into the bowl, and then you need to be able to lift the fork out of the bowl and observe what happens. And so I have the fork immersed in the honey, and you're going to see that really it's a very thin strand initially, and then it starts to sort of separate into dollops. So really this honey is not behaving as we would describe a moderately thick liquid. The stream is too thin through the tines of a fork, and so this is displaying a product that may change its behavior in certain conditions. Temperature would be a relevant factor to understand here as well, but really this is a little bit too thin once you apply the fork drip test. And so I've got a second liquid here that I want to demonstrate fork drip testing with, and that is a commercially available Plum Sauce. And so here I have it in my container, and I'm immersing my fork again, and I'm going to lift it up, and you'll see, in contrast to what we saw with the honey, that here we have dollops falling through the tines of the fork. I'll show you again. Try and get a little bit more on my fork. So with moderately thick liquids, it's actually quite difficult to load a reasonable amount on your fork because it falls through the tines of the fork. And this is a good example of a liquid that is behaving as a moderately thick liquid and dolloping through the tines of the fork. A third example I want to show you is applesauce. And applesauce is used very frequently in dysphagia management. It's often used as a way to serve pills, for example. And people have assumptions about applesauce, and yet applesauce can vary in its consistency from brand to brand. So here I have a commercially available applesauce, and I hope you can see here that it has some lumps in it and maybe some looser or more liquid components to it. And so really it's not smooth enough to meet the requirements of Itsy level 4 in this state. If we were to do the fork drip test with this product, it can easily load and mound on the fork, and it doesn't drip through. But because there are lumps in this applesauce that I think you can see clearly, it's really not meeting all of the definitions of an Itsy level 4 extremely thick liquid. So I threw it in my blender before recording here just for a couple of seconds. And so now I have applesauce that has been pureed so that it's more smooth. And the question is, does it still test as an Itsy level 4 extremely thick liquid, and what does it look like on the fork drip test? So here I have a fork and my product, and here you can see pretty well a stereotypical level 4 Itsy fork test result, where we see a tail of the applesauce hanging through the fork but not actively.
Thanks, Peter. That's great. Thank you. So in order to manage the risk of residue, so now that we've looked at how thick a liquid is, we also need to consider whether it's too thick. And when liquids are too thick or sticky, we're worried about residue being left behind in the pharynx. And recent evidence confirms that residue in the pharynx does increase the risk of aspirating on a subsequent swallow. So next slide, please. On this video fluoroscopy example, we see a patient who has residue in the pharynx after their swallow. You can see it there in the vallecula and also down lower in the piriform sinus area just above the upper esophageal sphincter. And really, they're having great difficulty clearing it. So we can move on to the next slide. So in order to manage the risk of residue, we want to make sure that thick boluses are not too sticky. And for this, we recommend using the Itsy spoon tilt test. And I'm going to ask Peter to go out again to another short video clip demonstration.
So in this second virtual active demonstration, we want to look at the spoon tilt test. And here we're looking at whether the product is sticky and adherent, and also whether it holds together in a cohesive bolus. And so for this, I've got those same two applesauce products that we had before, the one straight out of the bottle and the one that's been in my blender for a couple of seconds. So let's start with the one that is straight out of the bottle. And so here we're going to again immerse our spoon, this time in the product, lift it up and tilt and see if it falls off in a cohesive bolus and what kind of residue it leaves behind. So if I tilt this spoon, you'll see that most of the applesauce fell off. There is still some left behind. You can see that it's sort of collected at the bottom of the tilted spoon. And at the top of the tilted spoon, it's cleared the spoon quite cleanly, only leaving a little bit of residue behind. So it's not demonstrating that it's very sticky. If we do the same demonstration with the blended applesauce that went through my blender, we get this result. So my spoon's in, I lift it up, it falls off in 2 lumps. This time we're seeing a little bit more coating on the spoon, but it's quite translucent and not very sticky. So both of these applesauce products would pass the spoon tilt test, demonstrating cohesiveness and not too much adhesiveness.
Thanks, Peter. So before I hand off to Joe, who's going to discuss tests for level 5 minced and moist foods, I just want to reinforce the message that we should never have assumptions about the Itsy level of a food or a drink based on the product name. And unfortunately, words can be misleading in this respect. And I've shown here on the slide just 3 situations where the name of a product might lead you to have expectations about the characteristics of that product that might well be wrong. Our guidance is that you should never assume consistency, and if you want to be certain, you should always test. We don't mean by that that you should constantly be running Itsy tests on every tray of every meal that gets served in your kitchens, but over time that perhaps you might establish a quality audit process where you have a sense of the range where a particular product should be falling, and you can do spot checks to make sure that it does remain in that level. And it's important for you as clinicians to know that we've been giving this message very clearly to manufacturers of products with names that might imply consistency. We've been asking them to base those labels and claims in Itsy testing and to communicate to you as clinicians and consumers of those products what conditions and results of those tests are in product information. And for you as clinicians, we encourage you not to assume that labels are always correct or that a food is constant in its characteristics, because we know that products can vary in consistency over time and particularly across temperature. So if you think that a product looks unusually runny or unusually thick on a particular day, you might be right. And that's the kind of online observation that we would encourage clinicians then, if they're uncertain or if they think there might be something wrong today, that's a moment where a check can be done. And remember that if you're in doubt, the safest thing is always to run a check using one of Itsy's testing methods, and in fact, using all of the mandatory tests for the level of food that you're testing. So with that, I will hand over to Joe.
Great, thanks so much. I really appreciated Katrina and Peter and Luis for inviting me to take part in this session. It's a lot of fun to work with everyone, and I think they've done some great work. So what we're looking at here is mastication of a food bolus, and it's important that we review this some. We'll just let it run in a loop. as we talk about levels 5 and 6 of the framework. Mastication is a really important component and concept to master here when we think about the activity and the end result of a reduced food particulate size. We're equipped with teeth, hopefully, that oppose other teeth that can act to reduce the size of food particles that enter into our mouth. They serve many other functions as well. We can bite with them, we can tear food away, as well as grind the food down to smaller transportable pieces that can be advanced from the oral cavity then and down into the gut. The originating whole food particle is limited only by the opening of the mouth, and the reduction of that whole food is where our attention turns, particularly for levels 5 and 6. Let's take a look at this video now of normal mastication of foods. So we talked about dentition and opposing functional units of teeth. We can see that the food is guided between the teeth for jaw activity to enact pressure between the teeth to reduce the particle size. All of this takes place very rapidly. We can see the teeth don't act alone. Of course, we have to have really good tongue function. There has to be a good sensory system to perceive the size of the food particulate and, of course, to sense where the bolus is in the oral cavity and where particulate needs to be reduced further. And so during this process, food is reduced in particle size, obviously. In addition, saliva is introduced, and this lubricates the food and readies it to be propelled to the distal pharynx and through the much smaller aperture of the upper esophageal sphincter. And so important things going on here in the oral cavity that contribute to our ability to take food in its natural state and introduce it into the gut. We can go to the next slide. And so oral processing behavior and eating rate, I think all of us as clinicians understand can affect nutrient intake and by association body mass index and overall health of an individual. And as we reviewed while we were looking at the video, certain abilities can affect food intake and choices. So dental status is very important. And I don't think we pay enough attention, particularly when we're doing oral motor exams, to looking beyond the tongue or looking at motor function, looking at teeth, and particularly looking at functional units or pairings of teeth is extremely important. Having singular teeth that don't meet another tooth reduces the efficiency of mastication. I don't think it's very hard to conceive of that, but it's very often skipped during an oral motor exam. Jaw muscle activity is extremely important. We have to have enough force to reduce the particulate, bite force, tongue pressure, and oral volume. And the inverse is true as well. We'll just move on to the next slide. The reduction in particle size is very important to create an environment where the food can be broken down efficiently in the gut. And simple aging can result in disability of all those different components that we talked about in the previous slide. Edentulism is very frequently seen in elders. Reduced saliva flow can result from aging, simple aging, where there's a reduction in the capacity of the salivary glands to produce saliva, as well as the iatrogenic effect of many medications, as well as things like radiation therapy and other treatments. And so very often people find themselves in a state where food is dry or individuals are unable to reduce the particle size because of lack of teeth. And this can result in pain and discomfort and can lead to fatigue and a reduction in oral intake. Patients, for instance, with neuromuscular disease may have good teeth or good salivary flow, but may have a weakness of jaw motion or bite force, and as a result, be unable to reduce particle size. We talked a little bit about post-surgical patients, and of course, if there's a structural change or associated weakness or reduced range of motion. We can run into a state where a patient's, again, unable to reduce particle size from whole foods and end up with a fatigue before achieving nutrition. And so our job here, when we look at levels 5 and 6, is to create a food that has been presented in a condition that matches some level of mastication, or that will not challenge a patient that has disabilities in this way. It takes some work and fine tuning and some attention, but if you have good teamwork, a good team, and a creative team in most care environments, you can create menus that fall within the descriptors of the framework. We can go on to the next slide. This is our team here, just a small portion of the team. This is one of our bi-weekly food testing labs. We can see the chefs in the background there with the epaulettes, and we have nutrition and food service workers. We have clinical dietitians, and even the fellows who deliver the food to bedside attend these labs, and they rate the foods for whether it tastes good, obviously, but also they rate it along the Itsy guidelines. So lots of work goes into creating these dishes. The chefs are very proud of the creations that they come up with, and I think we've had great success filling our menus in the 5 and 6 gaps that I think many people are challenged to do when they look at the framework initially. But what we're going to go through here is we're going to look at a couple of dishes that were prepared for one of our food lab testing kitchen events here, and we'll see what the results were. So we can go to the next slide here. First, we'll talk about the measurements that we use. And the very first measurements we'll talk about is the fork pressure test, and we're going to talk about minced and moist foods. Minced and moist foods are created for patients where they may have an inability to bite well, so they can't tear off pieces of food, where minimal chewing is required, where tongue force alone can't be used to separate small particles. Tongue force, of course, would be required to move the bolus in the oral cavity. Patients may have pain or fatigue on chewing, or they may have missing or poorly fitting dentures. And so the measurement test that we use to determine whether this particle size has been achieved is to use a very simple, readily available, and surprisingly globally standardized fork. I think Katrina discovered that the space between fork tines is approximately 4 millimeters in size. And so that gap proves to be, for most forks, a fairly good means for testing the maximum particle size. The minced and moist particle size also matches food that's gone through a masticatory cycle. And so this means for determining whether food matches a state of having been masticated is easily measured using the tines of the fork. And so we're just going to press the fork against the food to see if it can be pushed between the tines. Now, the addition of the minced and moist food items into our menu selection in our hospital has been very popular with the patients, and I think it's a really important component of the framework. And we're finding that the process to achieve a puree texture often includes a pulverization of the cellular structure of the foods. And with puree foods, oral manipulation of the food offers no opportunity really to express fluid from the structure of the food that remains after that pulverization. And so the liquid from the cells of the food becomes suspended throughout the texture on the plate. In level 5, minced and moist, though, there's enough of a remaining cellular structure to contain liquids and juices that can be pressed either by the gums or by remaining teeth or by the tongue against the palate. And we get the expression of the food and juices and mouthfeel that more closely matches the whole food as it's being masticated. And this has been really popular and a much more pleasing texture for our patients that previously were consuming pureed textures. Let's move to the next slide. We'll just show some of the dishes that were created for the minced and moist. This is a chicken tetrazzini using a very small pasta. We had a little bit of trouble with the reheating of this particular dish. When they reheated it, the sides became crusty, and so that was a note that the chefs had to work on to create a moist dish that sustained moistness throughout the entire dish and arrived at the bedside in a condition that matched the measurements. If we go to the next slide, we can see this was another pasta dish that was created. I believe it was a substitute for a lasagna. And again, they used a small orzo that matched the minced and moist particle size, was very pleasing, matched the original mouthfeel of the pasta in its whole state, and was much more readily received by the patients who were consuming it on the trays. So we'll go to the next slide. We're going to have a video here. And what we're going to see in this video is a cod dish, and we'll see this in other states as well. We have peas and carrots. We're using the spoon tilt test. We see it's cohesive enough to stick together, but falls off of the spoon. We can see the fork pushes the particulate through. Now what we can do is take the largest piece and place it on one of our index cards, and we can see that it matches the 4 millimeter adult particle size. And so this is a very simple, very quick way of looking at different particle sizes for the minced and moist. If we go on to the next slide, we can talk about level 6 now, and we'll use the same instruments for level 6. Level 6, the rationale for employing this level, again, this would be a patient who perhaps cannot bite sections of food off, and so the food is now going to be limited to 1.5 centimeter pieces. So a 15 millimeter square should contain a particle of food that could be considered qualifying for the soft and bite-sized framework descriptor. Right, so chewing is required with this particle size. Food piece sizes are designed to minimize choking risk, and we're going to talk about that in just a little bit. Tongue force and controls required to move the food and to keep it within the mouth for chewing and oral processing, and to move the bolus back into the pharynx to initiate the swallow. It's useful for patients that may have pain during mastication or fatigue on chewing, and perhaps also patients with missing teeth or poorly fitting dentures. And so the particle size is slightly bigger, as we described. We're looking at a 15 millimeter square particle now. And we're going to now measure the particle size using our same index cards, but we're also going to look at the domain of softness of the food. And this is easily achieved by pressing the fork against the food particle. Now, again, Katrina's lab was instrumental in creating some research that described the pressure necessary to blanch your thumbnail when you're pressing against a particle of food with the fork. And 17 kilopascals actually is needed to achieve this blanching of the thumbnail, and it's very similar to the reported amount of pressure used by the tongue in swallowing. And so we have a nice, I think, easily repeatable test here to determine whether food is soft or not, using the fork again. So let's move forward just a bit again, and we're going to look at a video, and I want to show this video to you. We're going to look at a video fluoroscopy on the right, and we're looking at a laryngoscopic image on the left. So we can see the laryngoscope placed through the nasal cavity and positioned in the pharynx to view the laryngeal airway. For those of you that are familiar with this view, just a very quick review for those that are not. And so please accommodate the explanation. What we're looking at here is the voice box, or the larynx, where the vocal cords are. And we can see that small delta-shaped opening there. That is the entryway into the trachea, and that's right at the bottom of the pharynx. And so the larynx serves as a little fortress. You can see it rises above the floor of the pharynx and creates barriers to the entry of food and liquid down into the lower airway. The actual opening of the laryngeal inlet there, the glottis as we refer to it, is fairly small. It looks fairly large in the image, but we're looking at an area that is not bigger than the size of your thumb. And so let's just go to the next slide here. So we can see that the larynx serves as a shield to the lower airway. And so we can see that as food exits the oral cavity, it comes down and it runs into the epiglottis, which acts as a prow of the boat or a snow plow, and guides food and liquid around it down into other containing spots deeper in the pharynx and out of the airway. The airway size in an adult is just slightly larger than that 1.5 centimeter square size that we're using for our qualification for level 6 soft and bite size. This size actually increases as when we're seated upright. So another strong reason to have upright positioning during eating. Opens the larynx slightly wider. All right, and so let's move on to the next slide. We can see here, I think we moved back. Yeah, let's move forward. We can see some liquid here arriving in the molecular space, and we can see how nicely the larynx acts to guide it down into the distal pharynx around the airway. So lots of passive function here in the laryngeal airway that is standing by and ready to help us. Let's move forward to the next slide. And we're going to see this cod dish now manipulated to match level 6 soft and bite size. So we have particle sizes that are larger, some too large. And so this triggered a review by the chef and the kitchen workers to review exactly how they're reducing particle size. The carrot in its pre-cut condition actually fell within the soft and bite size domain, as well as the peas that were on the dish, but the cod needed to be further manipulated. And so notes were made, sizes were reduced, and we ended up with a more compliant dish to the framework. Let's move on to the next slide. And so this is going to be a looping video again. And what we're seeing is someone with either poor masticatory ability, poor cognitive ability, perhaps a combination of those two things, but we have a whole particle of food here in an unmasticated state being advanced down into the pharynx and into the open laryngeal airway. And you can see it being guided out of the oral cavity without mastication, and it falls into the airway there and rests there momentarily before it's expectorated. Very dangerous situation, one that we want to avoid, and one that is a key component of the creation of level 6 soft and bite-sized. So should this go into the airway and cause an obstruction, this would require an emergency intervention if the patient was unable to clear it from the airway. Aspiration and choking and asphyxiation are the key safety issues in children and adults with dysphagia, and specific food characteristics are associated with increased choking risk. If we look across the globe, deaths in all age groups have occurred from choking. There have been incidents where this is due to misunderstanding and miscommunication with the use of diverse, inconsistent, and sometimes confusing terminology regarding the safest and most appropriate food textures for an individual. And aspiration, of course, can also lead to pneumonia requiring hospitalization for elderly or compromised individuals. And of course, a severe pneumonia can lead to mortality. And so let's move forward if we can. And we're going to just go through a little demonstration now using food particles that come pre-sized. I think our assumption is that we can always assume that there is some uniformity in food that goes through some industrial manipulation and is labeled before it comes to us. But I can't stress enough the importance of local mapping to look for variation in size, and occasional remapping to assure that there's been no change in the products that are being used in your kitchen or by your patients when they return to home. And so let's take a look at these particle sizes of pears and peach dices. And we'll take a look at a couple of pieces and employ the laryngoscope to look at the particle sizes for potential airway occlusion. Here we can see a peach has been placed on the index card, slightly larger than the 15 millimeters square. And so let's move to the next video here, and we're going to take a look at some particles of unmasticated peaches. We'll look at them on the index card, and then we'll look at them as they're advanced back into the pharynx. So here's a piece that appears to fall within the 15 millimeter guidelines for qualification for a soft and bite-sized texture within the framework. And so the language matches the size. As we advance this exact same piece that we looked at on the index card, it no longer looks like a small piece of diced fruit, but instead looks something like the Rock of Gibraltar when it's resting near the airway. Now remember, this is a particle size that falls within soft and bite-sized. And we're going to see it rest there for a moment before a swallow occurs. And it's advanced without penetration or aspiration. This is a particle size that's larger. You can see that a portion of it extends beyond the 15 millimeter range. Let's see what this looks like when it's advanced back into the pharynx. We can see it's advanced down into the laryngeal vestibule. It's a little bit jumpy here, but we're going to slow it down so that you can see it fall into the laryngeal airway. Now, I think you'll agree that this particle size completely occludes the laryngeal airway. If it were to fall within the glottis, there could be a great hazard and asphyxiation risk. And here we can see it being contained in the laryngeal vestibule and then expectorated. And so just very small changes in the dimensions of some of these diced items can result in the difference between a safe particle size and one that's relatively unsafe. We can move to the next slide. So as we reflect on this portion of the session before I hand it to Luis, I'd like you to think a bit about the framework here, this middle part of the framework, and reflect on safe swallowing, and think about the appropriateness of a particle size for oral preparation of the bolus. Think about the efficiency of the propulsion of the bolus and the speed of the onset of the swallow of the individual who will be consuming this food. I think it's very important for our patients to be assessed in a rational way and to recommend these middle portions of the framework for those that may have some choking risk with larger particle size, who may be unable to break down food into particle sizes that are compatible with their ability to safely propel it past the airway and into the lower gut. And so all with the intent to give them a pleasant eating experience and one that results in greater oral intake. And my experience, at least in our hospital system, is that including levels 5 and 6 have been a great boon for oral intake and for presenting patients with menu items that are pleasing both in mouthfeel and visually. And with that, I'm going to hand it over to Luis Riquelme to talk about the upper portion of the framework.
Well, thanks so much, Joe. I have to tell you that if there's anybody right now in the audience that feels bored, then I think that they have to pinch themselves, because those videos are just so incredible. And the explanations that both you and Dr. Steele have presented are just so clear, and make, and really help us make this all so much more understandable. And I agree with Joe. Levels 5 and 6 were also the ones that when we did our mapping at our hospital, we discovered that we were short on in terms of menu items. And so that's when our chefs got creative and started having fun, and came up with some interesting dishes that, and luckily, Joe, you shared some of what you've created. I have yet to take pictures and do all that cinematographic approach. But okay, let's talk about, so this level 7 easy to chew. So what is this? So this easy to chew level 7 is a subcategory of the regular level 7. And this subcategory was created following a global request to have a category for softer foods for people who have mild issues with oral processing or show some slight fatigue during chewing. I often say to my colleagues that are dietitians that, the level 7 easy to chew is often that softer diet that they might recommend for the patient that does not present with a swallowing problem, but that might have some trouble chewing, maybe left their dentures at home, and so they are they need some further support. Okay, it's not recommended for people who are at risk for suffocation due to incomplete chewing, taking too large a bite, or eating too quickly. Okay. The fork separation test and fork pressure test are used to determine if a food is soft enough and can be broken down easily. And you can see those here, and you understand what those are now after the great explanations we've seen earlier. Next slide, please. So here I'd like you to pay attention to the oral processing, right? And that will be looped again. So this person was able to chew this easily and propel the bolus into the upper esophagus, right? The airway remained clear and no major residue was noted in the pharynx or the throat, unlike some of those other videos that we saw. Next slide, please. So the fork pressure test, right, that blanching of the thumbnail, or the fork spoon separation test are really helpful to determine if foods are easy to chew. So always think about the potential for choking related to particle size. I would like to remind you, and we are speaking to clinicians in a few different fields right now, but it's important to remember the influence of taste, temperature, texture, and volume on our response, even during the oral stage, during oral processing, to sort of coordinate and program the entire swallow. So important to remember, and also remember that on the Itsy website, we do have the manuals available describing each level and also providing all the testing methods. So make sure you have those handy. Next slide, please. So here's an interesting slide, and thank you, Dr. Steele, for these photos. When mixed with saliva, this bolus forms and can be swallowed easily by a person without dysphagia. In this case, these were raw carrots chewed 20 times by 4 different healthy adults. So just think about that. 4 different adults chewed baby carrots 20 times. Okay, and this is what that looks like. So look at the difference amongst healthy adults. Next slide, please. Now, lots of questions always come up about transitional foods, and those I will share with you are often the more difficult ones to classify. These are foods that may start at a level 6 and change to a level 3, for example. Think of ice chips or the delicious potato chips, or there in your top left, you have plantain chips, which are quite culturally relevant personally. So not much chewing is required. And these foods are often used with children that present developmental delays or disorders, or with adults that may need rehabilitation for chewing. We need to attend to what level food texture is being swallowed once it has become in contact or mixed with saliva. We have to take temperature into account, and maybe even if it has been mixed with water. So these aren't typically used with people with dysphagia because of the risk for choking. Next slide, please. So the concern always is, well, how do we test transitional foods, right? How can we take an item and then test it and assume what will be happening at the point of when the oral stage is ready to propel the bolus posteriorly and trigger that swallow. So again, the fork pressure test, right? The thumbnail blanching and the sample that doesn't return to its original shape once the pressure has been released. That's really what you're looking for. If you look at this slide, you see that you're using, your sample, right? The 1.5 centimeters by 1.5 centimeters. You add 1 milliliter of water to the sample. You wait a minute, and then you apply the fork pressure test. Okay, so the shape should remain, and that's the idea here when you release it. Next slide, please. Mixed consistencies are also an item that we get many questions on. There are foods like soups, for example, that present with a variety of textures or Itsy levels in one serving. These may present danger to a person with dysphagia, right? The food item served must be tested, but also the liquid. These then need to match the Itsy levels that are safest for the particular patient. So remember that we're talking about texture modification for foods and texture modification for liquids. And so we have the 2 triangles. So for example, if you are not on a texture modified diet, you are most likely to be a 7-0. And that would mean a level 7 for food and a level 0 for liquids. So when we have these mixed consistencies, the point is you need to test them separately and see if those are safe for the patient to handle. Next slide, please. These are just a few other examples, some fruit cups that are quite popular, and I think Joe did a great job at advising us to take a look at particle size for sure in these fruit cups, but they also come with a syrup that is different consistencies and need to be tested, mixed for sure. So again, look at the food level, look at the liquid level, and make sure that they're appropriate for the patient. Next slide. So I just need to share these free materials that are available on the Itsy website. Downloadable, you can use them, you can figure out what might be the most appropriate materials to use at your facility. But here you have, I think of it as a little bit of a cheat sheet, right? Sort of giving you an idea of at the different levels, what what are some of the tests that you can apply to the materials that you think might qualify for that level, and see if they really fall in there. Or as you're testing, sort of what are the tests I have to do? Is it the flow test alone? Do I need to do something else? Do I do the fork drip test and the spoon tilt test, etc. So this is a really, really, really handy reference. Next slide, please. And here's another wonderful poster that is also downloadable and available for you to print at itsy.org, where it actually explains the different levels, okay, in the framework. Again, not Itsy diets. This is a framework for the texture modified foods, and we're describing the foods and the liquids. So this just puts all the little pieces together, as you see, in one place. And in the interest of time, we'll just move on to the next slide. These are, again, materials that you can download from our website. Next slide, please. There you go. These are test cards, right? Little business cards. And so let's quickly chat a bit about implementation for just a few minutes, again, in the interest of time. So let's see the next slide. As an audience, and from looking at the poll at the beginning, you were, we have a mixed audience in terms of where you are with implementation of Itsy at your facility. So probably at this point, you figured out who the leadership team is going to be, who some of the other key players are, who needs to approve moving forward with the implementation of Itsy. But I want to make sure that you don't forget the next level of target supporters, which are usually the clinical staff. So the folks that work in food service, also the rest of the speech pathologists, the rest of the registered dietitians at the facility, because buy-in can't just be by the leadership team. You need buy-in from the rest of the group as well. Next slide, please. And so again, figuring out how you're going to do the mapping, how you will deal with the results of the mapping. And by mapping, I'm sure you know that it means testing all the items on your current menus and classifying them by Itsy level. Now, remember that you might be in one facility that maybe, let's say, is the sister of another facility, maybe a mile away. Well, you need to test the mashed potatoes at each facility, for example, because the recipes might not be the same, the chefs might not be the same, etc. So one of the things that I've learned from our executive chef is how because of the Itsy framework, many times now kitchens are paying more attention to their recipes and to the fact that one food item should not be different based on who the chef is on duty that day. Next slide, please. All right, again, this is transitioning over. In the interest of time, I would like to show you some of the slides. I'll let Dr. Murray show you some of the slides from some of his experience now at the VA. But again, looking at the tools that you might need as you move forward. And for levels 5 and 6, we needed that. And then how can you transition? Think about the computer systems, think about the ordering. And my last big piece of advice, never forget to involve nursing early on. Nursing education is one of the reasons that we're not fully implemented yet, and it's because they had a lot on their agenda. In addition to, of course, this pandemic that kind of put a stop on everything. But nursing education is something that needs to be addressed. And in retrospect, I should have probably worked with our leadership team to address it earlier. So start that early on so that you can figure out how the education for nurses will take place. Next slide. And so let's talk about the VA, Dr. Murray.
Oh, thanks, Luis. That was just great. And I'll just very briefly talk about our experience at the VA. VA is a big a hospital system, a care system that serves millions of veterans across the country. We have 364 sites that serve food. Now, I know that's not as big as some government, other government health systems or provincial health systems in different countries, but it's big by American standards. And so we had many thousands of staff that needed education and training in Itsy before we could even think about preparing for it. And so everybody that was involved in serving food, preparing food, delivering food, ordering food, helping patients with feeding, really needed to be informed about this. And so you can see our list there: registered dietitians, speech pathologists, food service employees. This is so important for lots of clinicians, speech pathologists, speech therapists that perhaps don't find their way into the kitchen. There is a whole world that I was introduced to by our implementation of Itsy. I met people that I didn't know worked in the building that are extremely important in the delivery of this framework, right down to the person who delivers it to bedside. Extremely important from beginning to end in the food service. And so we had many, many, many different education events with the food service staff. They asked excellent questions. They gave us excellent advice on how to create food that would match the descriptors of the framework. Nursing, I think Luis said this, and it's so important that they're on board and understand it. Many, many, many good different printouts, posters, PowerPoints that you can download from the Itsy website that can be used during training sessions, even brief 2-minute talks during transitions between staffing is really important. Physicians had to be on board and aware of the changes, and we had to create order sets in the computer to make it easy for them. And so we employed a panel of physicians to review what those order sets would look like so that confusion was minimized and they understood what the different levels meant and how they translated to pre-existing descriptors. And PTOT as well. Just about everybody that was going to come in contact with a patient who would be eating. In our particular site, registered dietitians and speech pathologists provided the training, but it really depends on the site and who's doing the work. Let's go to the next slide. We can't forget about, we've talked about inpatients, or at least I have, in preparation for them and serving food there, but we have to remember our outpatients as well. I'd recommend that you work on creating a take-home kit at your facility that's designed to inform caregivers or a patient that perhaps is a self-care giver, so that they're organized and ready to go home and create, for instance, a thickened liquid or be able to test particle sizes of food. And so many, many, again, patient handouts and information sheets available that are quite complete and good on the Itsy website. Here you can see a take-home kit that was created by our Manhattan VA that's been implemented at a number of our sites now. It includes a fork, testing cards, information on how to mix thickening agent with instructions and the thickening agent, of course. Next slide, we also include syringes in our array of take-home items, as well as multiple testing flow cards, making sure that they understand the flow tests. Next slide. We, in the North America at least, are using BD slip tip or lure lock syringes, and you can see the item number there. These are widely available. They can be obtained through supply chains in your hospital. I think the argument for purchasing these is strong. If you run into resistance, I would recommend that you contact your patient safety advocate in your hospital system to assist you in acquiring these items, because patient safety is what Itsy is all about, and they would be happy, I'm sure, to help you. Finally, pharmacy needed to be informed at a national level to change our computerized medical record system so that language that matched IDDSI terminology was included in our national descriptors for pharmacy dispensation of items for thickening, for instance. And so important that you include all of these different components, not just in education, but in preparation. And so lots of meetings with these different groups to make sure everyone's on board and understands the process at a level that makes everyone comfortable for implementation. And I'll hand it over now, I think, to Peter.
Thank you, Joe. Thank you, Luis. Thank you, Katrina. So we thought at this point, we just kind of figure out how you feel about Itsy implementation. So I'm going to ask Alan to please launch the next poll, please. Thank you. We'll just give it a few more seconds for people to vote. Excellent. It looks like after a bit of a horse race there, level 3, moderately ready is what most people are feeling. We have some people extremely ready. Just only a few people feeling not ready at all, but we're hoping that we'll get you there soon enough. Thank you very much for participating in that poll. We're going to pause at this point and take any questions that you have, and then we will summarize to close off in about 10 minutes time. Once again, I'm just going to remind everyone, if you have a question for the panelists and the presenters today, please feel free to type your question into the Q&A function, and we'll be happy to address those. I'll start off with a question from University Health Network Toronto. Amanda, thank you for your question. The question is curious on how to approach and classify popsicles and Jell-O. Katrina, I think you were going to answer this question.
Thanks, and hi, Amanda. In fact, Amanda's got 3 questions, and I'll try to deal with them all together, as well as a question lower down from somebody else about ice cream. So a couple of things I want to point out. So Amanda's asking about how to approach and classify things that start in a frozen form and melt, or Jell-O being something that starts in a solid form and may become thinner, particularly with temperature. And so these would be, they would fall into the category of transitional foods that start in one form and change to another. Our recommendation, in fact, is that the most knowledge comes if you can characterize both ends of that transition. So, and I've started using a sort of convention with an arrow in between, so that it might start at level 7, it's completely solid and frozen perhaps, and then an arrow to indicate where does it end up once it transitions or melts in this case, and that might be all the way to level 0 thin, or it might be somewhere along the way. And so it's important for describing the food to know what the range of levels is that it covers as it transitions. A related question is about mixed consistencies, where you have 2 consistencies together. There are lots of examples of these. Amanda's asked about cereal and milk, chunky soups. And here she's actually asked a question, can these products be served for patients whose diet recommendation is between a level 0 for thin liquids and a level 6 for foods? And so this one's actually a little harder for me to answer, because the question about whether it can be served to a patient is a question that I would want a clinician to make the determination on. And so it's possible that if a person can tolerate thin liquids, but needs a level 6 soft and bite-sized food, that they would be fine tolerating a mixed consistency that has those two components. On the other hand, for many people, tolerating a mixed consistency is extra challenging. And so this is something that the clinician should evaluate and decide whether for that particular patient that is something they would recommend or not recommend. And then Amanda has also asked a related question about condiments. And so how best to address this? She thought it was a silly question, and I don't think it's a silly question at all. So condiments, when they're on the food, things like mayonnaise, or perhaps nuts on the top of something. Amanda gave the example of brown sugar. When they're on the food, they may create a situation of a mixed consistency and should be handled in that way. But Amanda's also raised a really interesting point here about the safety of delivering those condiments on the side, on the tray. And is that a risk, just in case the patient consumes it by itself? And so that is a safety risk. In fact, we've heard of adverse events in some places where thickener has been served on the side in a little cup and confused by the patient as food and ending up with very serious adverse events. So I think, again, this is a clinical risk that the clinician should think about, should comment about whether they think for this patient condiments can be served safely on the tray or should not be for risk mitigation. I think I've covered that. I just wanted to also add that on our website, we do have a frequently asked questions area, and many of these issues are addressed there. We're actually right in the process now of upgrading our website, and we hope that it will soon be fully searchable, and that will make it easier to find this kind of information.
Thank you very much, Katrina. Next question comes from Belfast. Finula, thank you very much for your question. The question is, at what age do you suggest children should move from 8mm to 15mm at level 6?
You want to one of us? Yeah. Go ahead, Luis. Go ahead.
Luis.
So that's a great question, and it really depends, especially if if it's a child that has feeding or swallowing problems. It depends developmentally where they are. So again, the clinician is the one that actually starts looking at that transition. I mean, the data that we have, and Katrina and Joe, feel free to jump in, and Peter, of course. The data we have is really looking at choking risk, and that's where we go with the particle size, right? So I believe that we're looking at ages 5 to 6. But honestly, as a clinician, I would say it depends developmentally where the child is.
Yeah, and I just want to say,
I think that I've also heard guidance that anesthetists look at the size of the pinky fingernail as a guidance on the size of the airway. And so if you've got a particularly small child, they may still have an anatomically smaller airway versus a larger child. And so that might be something to look at to try to get a sense.
Thanks, that's a great point.
Thank you. I wanted to also just let everyone know there actually is an FAQ on our website regarding this question of when to transition between pediatric to adult sizes. Dr. Julie Chicaro was kind enough to compose an FAQ for us, so please go to our website to look for that. Next question comes from Jacqueline. Struggling with making this education client friendly. Any tips on simplifying it to increase their confidence at home?
I saw that question. Can I jump in?
Please.
So that's an interesting process right now, and of course, the goal of Itsy and the vision of Itsy has been across all care settings, right, and across all cultures. So we do have on the website materials for caregivers, typically not what we've asked volunteers to translate. We've really focused more on our two main manuals on the descriptors and testing methods. However, some groups of volunteers across the globe, basically across languages, have started to translate some of the caregiver materials that we have available on the website in English. So if you look in resources on the website, you'll see some country-specific resources, and that might be helpful. I think the other big piece, because there are different foods and we can't talk about or can't talk to every single food, when a patient is going home, is that many people have, or most people have, smartphones right now. So they can download the Itsy app, either on iOS or Android, and have access to all the videos and the information on the different consistencies once the clinician has recommended particular levels. So I think hopefully that's helpful.
Thank you, Luis. Next question comes from Worcester. Megan, thanks for joining us. What level would you recommend starting to introduce bread? I know it's a big choking risk, so curious about what level you think SLP should assess for readiness. Katrina, I think you'd like to answer
I'll take this one, yes. Yeah. So Megan, you're right, bread is recognized to be a big choking risk. In fact, it's really one of the most common causes of death by asphyxiation is with bread. So we're really very concerned about the safety of bread. And we also recognize, though, that bread comes in many different sort of textures around the world. And so the first thing is to test the bread that you have available, but bread, we believe, will only be suitable for people who don't have choking risk, which means that it's up in level 7. There are a couple of clinically formulated breads that come. They may have labeled pureed bread or with the word gel in the label. And those you can evaluate and see if they might fall somewhere else in the framework. The thing here is that as speech pathologists, we don't actually have right now a really good test clinically to know about a person's choking risk. There is a relatively new test of mastication and on solids, the Thomas, developed by Dr. Huckabee's lab. And here I think I would recommend to you that the most practical thing you might want to do, first of all, is to experience that bread yourself as somebody with healthy chewing and oral processing. Chew it up and actually spit it out and test it after you've done the processing so that you know what consistency it is at the point where it's sent into the pharynx. And secondly, to really explore the oral processing skills of your patient. So you may, in fact, if they're cognitively able with you, want to do some of that oral processing and then expectoration into a bowl and look at the properties of a food after it's been chewed to see whether you think their oral processing is adequate or not. I think this is something where we're going to need test development in the future.
Thank you, Katrina. Michelle, thank you very much for your question. Michelle from Prince George University of Northern BC. What layman terms can we use to tell patients' families what consistencies mildly thick, moderately thick, etc. are, since nectar thick and honey thick may not be accurate? Michelle, I think hopefully now that we've presented the Itsy flow test, that really is the best method to advise families to use to check what level of thickness a liquid is. There are videos readily available for them to watch, and the flow test cards are, again, readily available for them to use. So please, by all means, send them to either of those resources. I'm going to go to Nicole, has a question. I'm always unsure of whether or not peas can be provided on soft and bite-sized due to the shells. These are okay according to the video. Joe, maybe we can get you to address that one.
Sure. I could imagine that an undercooked pea may have a very thick shell. I would recommend that you map it using the fork tine test. These should be cooked to comply with the pressure test from the fork. And so if they're cooked long enough, I think that they're mashable and acceptable. If they're not cooked long enough, I think you could run into trouble. I don't think I would qualify it just by the type of food it is. I think you have to look at it in its serving state and test it according to the framework. Just map it and see what you end up with. Hopefully
Great, Joe,
that helps.
And I'll get you to hang on because there's another question from Marissa. I have a question about the fork pressure test. Can the tip of the thumbnail turn white at all and pass the test for level 5 minced and moist? My staff find it takes very little pressure for their thumbnail to start turning white and therefore having some confusion when evaluating foods for level 5.
Well, that's, yeah, I could imagine that would happen. I don't know if Katrina would like to add anything. They did some really nice review.
I think the point is that we're wanting to see what happens to a food with very little pressure. And so it is a calibrated standard, how much it takes for the thumbnail to blanch, and we want to be, you know, just at that boundary or below.
Great,
and
thank
so
you.
If you have somebody with an easily blanchable thumb, they have some sort of precondition that results in that, I would suggest that they borrow their neighbor's thumb.
Yes, I think so. And by the way, we did go and check whether people with different skin colors have similar blanching of the nail and confirmed that that is the case. So this should be a universally achievable observation.
Thank you very much. It looks like our time is almost up because we're about half past the hour. We have quite a few questions still left unanswered, but we'll try to do our best to answer those in upcoming FAQs or post them in our e-bites in write-ups in future publications. Just quickly to let everybody know, there have been a lot of questions about what can we include and what can we not include, what should be included or not included on product labels. Go to our website and have a look at this handout that we've prepared for you. We have been talking to manufacturers to ask them to not mislead people by using including the Itsy logo. You should not see any Itsy logo on any commercial products. We ask you to do the same with all of your education materials. Feel free to use the Itsy framework as we've shown you on the website, but please do not use the Itsy logo itself. Just because we don't want to mislead people to think or have people misunderstand that it is actually something produced by Itsy. There are guidelines about how to create these materials, what you can or cannot include. And again, these are available on our website. And then finally, we can't emphasize enough that, as Katrina said, Itsy is not a prescription. So please don't, say to patients, yeah, we want you to be on a soft and bite-sized diet, or we want you to be on a moderately thick diet or liquidized diet. We really are inviting all clinicians to help support us to get this message out there. And finally, this is a website that is going to be refreshed in the very near future. We do ask you to check back as we often will update things and include new materials. Send other people to the website. And if you have not signed up for our newsletter, please do so. We wanted to also tell you that there are lots of reference groups that are now up and running in all these countries that you see here. Most recently, the United States and Territories group is just getting formed, but also in Germany, Austria, Hong Kong, Taiwan, Singapore. If you're interested in joining an existing group, please email us using the subject title as interested to join Itsy reference group, or if you do not see your country listed here and you wish to help start one or get a group of people together, again, email us at office@itsy.org, and in the subject line put interested to help start an Itsy reference group. I want to thank Katrina, Joe, Luis for taking the time to help present this webinar today. Again, as board members, we're all volunteers, and we know that all of you are helping with the Itsy implementation, also through volunteer time. We do this because we want to promote safety through the use of common terminology for all ages, all care settings, and all cultures. We just want people to know that this webinar, as we mentioned, has been recorded. It will be available on the Itsy YouTube channel within a couple of weeks, should you wish to watch it again or share with your colleagues. And again, certificates of attendance will only be sent out to participants who have joined us today for the live webinar. If you are watching this after the fact on YouTube, unfortunately, we will not be able to verify your attendance, and therefore we cannot issue a certificate of attendance. We thank you all for joining us once again. We look forward to seeing you on a future webinar, and wishing you good health, keep safe, and keep well. Thank you very much, everyone.